Thank you for joining us for today's presentation. This is Strategies to Identify Risks of Self-Harm and Reduce the Incidence of Self-Harm and Suicide. This webinar is sponsored by the Rural Veterans Health Access Program and provided by the UAA, Alaska Center for Rural Health and Health Workforce, the Alaska AHEC. Now our participants will be on mute. All participants will be on mute during the presentation. If you wish to ask a question, you can type it into the question box at any time, and there will be time for us to answer those questions at the end. A copy of today's presentation can be downloaded from the Handouts tab in the sidebar. Now we are joined today by Susan Maley, Program Director for the Rural Veterans Health Access Program, who will tell us about the RVAC project and introduce our speaker. Welcome, Susan.
Thank you, Pat. The Rural Veterans Health Access Program is very pleased to be able to present Dr. Bautenheimer's presentation. This excellent presentation has already been a resource for providers in the VA system and out of it in Alaska, and this webinar will make it available to people in the future too through our website and also the AHEC's website. The Rural Veterans Health Access Program is part of the Rural Community Health Systems section in the Division of Public Health, and we are funded by the Health Resource Service Administration Office of Rural Health Policy. And the goal of the Rural Veterans Health Access Program is to utilize telehealth and health information technology in order to enhance access and quality of mental health service and other health services for veterans who are residing in rural areas. In order to fulfill this goal, the RVAC supports telehealth networks for veterans, including video-linked statewide availability of counseling with experienced mental health clinicians for trauma and other emotional concerns, crisis intervention, and webinars such as this to expand the healthcare access through skill development of providers. For any other information, please feel free to contact me. And also, in addition to being able to access the recording and PowerPoint slides of this webinar, there are 6 other webinars on traumatic brain injury and one on suicide risk with TBI and veterans that are available on that page. And now let me hand things over to Dr. Bautenheimer.
Thank you, Susan, and thank you, Pat, and welcome everyone to the discussion today. We have an interesting, diverse group of folks. I was looking at the registration. Most people are in the treatment sector, mental health treatment sector, but there are others as well. The discussion today is designed primarily for clinicians in the mental health field. And the purpose of this discussion is to hopefully provide some useful tools that people can use in their practice when working with veterans and other patients to deal with a very difficult aspect of our work, which is the prevention of self-harm and suicide. So as you can see by the title of today's program, it's not just suicide prevention, and that's for a reason. It's really to the core purpose of the discussion today. It is to try to look at suicide as one point on a continuum of self-harm, from where patients are not entertaining any thoughts at all of hurting themselves to the point in which they feel that they would prefer to end their life. And we will tailor our discussion to pick up on that theme and to provide you hopefully with some useful tools to help you better assess your patients where they are in that continuum and to aid in our ongoing effort to prevent suicide. So this is me that you see on the slide. I put my 2 email addresses, business. I do work at the VA here in Anchorage, and I also provided my personal email address. And you are welcome at any time to contact me if you have questions about this presentation or related subject matter. I'll be glad to respond to you in a timely fashion. Okay. So disclosure, I'm not compensated for this discussion. I don't, if I were to mention any medications by name, I don't expect that I will, but if I do, I don't have any relationship with any pharmaceutical company. So I just wanted to let everyone know that. The goal is to provide additional or alternative tools that you can use as you assess the likelihood that a patient may try to harm himself or herself. And we want to look at the psychological antecedents that increase the risk along that continuum that I spoke about. Yeah, it's not going forward. Okay, next slide. What this is not, it's not a discussion of what typically takes place when there are discussions about suicide, which is usually starts with a discussion about the epidemiology and the seriousness of suicide. We're all well aware of that. It's not going to be a discussion about treatment modalities specifically as regards medication types or different types of psychotherapy. We'll make some mention of those as part of the tools that we use when trying to address patients who are on that continuum of self-harm. And we're not going to speak about underlying disease states either that may be associated with suicide. What we will do is we'll make reference to those states in terms of how we can look at the emotional overlay that occurs during these states, such as depression. One of the things I'd like to start off with, though, is first of all, compliment those of you who are in the mental health care profession. It is not an easy profession. I've been in it for several decades now. It is a very difficult, very trying, but extremely useful. You're doing extremely important work, and that's where the thank you comes in. And also a concern. I want to say that this is difficult work. It's difficult if we're working with patients who may be contemplating suicide, have made suicide attempts in the past. It's emotionally difficult for us as well as for our patients. And I just would like to emphasize that we need to take care of ourselves. We need to recharge our batteries so that we can do a better job with our patients. One thing I do like to remind both myself and others when working with patients who may be suicidal, you're not just working with the patient, you're working with the family, you're working with the community. As we know, too often, if someone were to end their life, it affects many people. It can have a generational effect. It can affect people not only in the family, in the workplace, and in the community in general. So as we're working with individuals, keep in mind that we're working with families and with communities. One of the first things that I learned in training as a physician that has stuck with me throughout the years is that the primary role of a healthcare provider is the reduction of suffering, of course, but also with preservation of dignity. And in light of that really fundamental role, there'll be several references during this discussion when I talk about some of the how-tos in terms of approaching and assessing patients' risk of self-harm that reflect that what we're trying to do is not only reduce the suffering, but preserve the dignity in the process of making that evaluation. Can suicide be prevented? The obvious answer, not in every case. One of the inherent, I guess, unfairnesses, if you wanted to call it that, of our work is that we're painfully reminded at times of cases where we feel we missed the prevention of suicide or self-harm. But we often don't know when the work that we do has actually made a difference and has prevented one of these acts. Occasionally I'll have patients come to me and say if this hadn't happened or you hadn't been involved or this person I referred them to wasn't involved, that they may have taken their life. But I don't take comfort in that. I mean, it's nice to hear. What I know is that our work is never ending and that we have to remain vigilant at all times for any of our patients that could get into a state of despair where they begin to think about hurting themselves. Okay. Just a kind of word about words. Words are very powerful. For those of us in the business of psychotherapy, we know that words are very meaningful. They tell us a lot about what is going on in the person's mind in terms of which words they choose, which words they emphasize. But in terms of suicide, one of the things that once this was pointed out to me, it's always stuck with me, and I wanted to kind of share that with you, and hopefully it'll stick with you as well. You'll hear people talk about whether someone had a successful suicide or not. Well, there's nothing successful about suicide. I don't even like seeing that word associated with it. Sometimes we also hear about someone made a failed suicide attempt. There's no failure in suicide. Words have meaning. The words that we use with our patients as well as the words that they use are very important, as you know, in the work of psychotherapy. So what I'd like to do, instead of using those terms that have a lot of stigma associated with it, I'll use terms such as whether or not a suicide was completed, whether it was a non-fatal self-harm attempt, or whether it was an aborted self-harm attempt. And I'll give some examples of that as we go along. Another thing I would like to point out is that we all do this at times. I mean, how many times have you asked a patient, are you feeling suicidal? I mean, we ask that all the time. But when you look at that, when you think about it, suicide is not a feeling. It's not a feeling state. Suicide is a behavior. It's an action. It's a plan. Actually, we're on the right track in terms of we're trying to understand what is the feeling behind the patient's decision or drive to act on those feelings, which is self-harm and suicide. So we're getting in the right ballpark, but what we're really wanting to focus on are feelings such as hopelessness and desperation, because so often those are the primary feelings behind that's driving the person to the point of trying to end his or her life. So suicide is behavior. It's a behavior that's carried out by persons who are feeling desperate and hopeless, and they are at an end of a continuum of self-harm risk. You'll hear me refer to desperate and hopeless a lot, because my view of suicidality is the patient that is most at risk for suicide is a patient who is feeling both desperate and hopeless. If you look up desperate in the dictionary, it'll talk about desperation as a sense of hopelessness, but desperation has a time element in it. It means that something has to be done right away to get some relief. And when you see that combination of someone who feels there's no way out, i.e. they're feeling hopeless, and something has to be done right away, they're feeling desperate, then, in my opinion, has someone who's at a very high risk. So one of the things about the epidemiology of suicides I alluded to earlier is we spent a lot of time looking at trends and how many suicides are there per year and within the veteran population, et cetera. And those are interesting, but we have to be careful not to be lured into feeling like, okay, if the numbers are going down, we must be doing something right, and if the numbers are going up, we're doing something wrong, because that's just not the case. The other problem with these numbers is the accuracy or the inherent inaccuracy of the determination of whether or not someone died by suicide. And I'll give a couple of examples of that a little bit later on in the presentation. One of the things for sure is that we cannot measure failed suicides. We can hear from patients whether they thought they were suicidal or not, but even that oftentimes it's not accurate, i.e. the patient was not actually to the point of wanting to end his or her life, but felt that they were somewhere on that continuum and they decided that they were suicidal and then will report to the clinician that, yes, I was suicidal. We'll talk about why, because of reasons like that, why we don't simply want to ask, are you feeling suicidal or are you not feeling suicidal? That really begs the question, and it's too much of a yes, no, go, no, no go, black or white demarcation of something that really is on a continuum. So things are not always as they appear, the uncertainty of statistics and even scientific evidence. We need evidence, obviously. Medicine can't progress without really good quality evidence and research. One of the problems, however, with suicidal behavior is you really cannot set up your classic study paradigms. You can't do double-blind, placebo-controlled studies where the outcome is death by suicide. You couldn't have two groups, for example. Let's take bullying in school as one of the causes or contributing factors to an adolescent suicide. You couldn't set up a study where you would have a group of adolescents who are getting bullied but had a teacher that would intervene, and another group of students who are being bullied and the teacher would not intervene, and then try to see who ended up killing himself and who didn't. You just could not set those up. The IRB boards would not approve those kind of studies. So we're really limited in looking at statistics. We're limited in looking at trends, and all of us as clinicians are limited, but in an important way, to our experience in working with patients and getting that inherent feel as to whether or not a patient is safe or not. We'll talk more about one's intuition as a critically important tool in that determination. So let me give you a couple of examples here, actually 3 examples of where suicidality can be misconstrued, either false positive, false negative, in terms of whether or not someone who looks like they're trying to harm themselves or actually died, whether or not it was a suicide attempt or not. So these are the 3 cases here. The first case, which I call the woman at the motel, this actually involved a patient of a colleague of mine soon after I finished training in Chapel Hill. He's a really, really good psychiatrist, and he had a very good practice back in North Carolina. And he told me once about this patient he had, and there was a woman, she carried a diagnosis of borderline personality disorder, and during the work of psychotherapy, she developed an erotic transference. For those of you not in the business, basically what that means is that the patient took a personal liking to the therapist and in her mind hoped to have some kind of romantic relationship come out of that doctor-patient relationship. One of the things that she did at times, she would test the limits and try to get my colleague to react to those wishes of hers. And at one point she actually called him, left a message on the telephone saying that she wanted him to come to a motel room to see her, that she was going to kill herself. Well, my colleague did the appropriate thing. He called for a wellness check. He did not go to the motel. That would, of course, be the wrong thing for him to do. And as you can see by the slide or the picture at the lower right-hand corner, this patient died. What had happened was she had taken an overdose of pills. She had calculated the amount of time she thought it would take for the psychiatrist to come to the motel from his office to rescue her, take her to the hospital, and I guess in her fantasy they would somehow live happily ever after. Well, he didn't show up, as he shouldn't have done, and he called for a wellness check. The timing didn't work out right, and she died. This patient got signed out of the emergency room as a death by suicide, but that was not her intent. Her intention was to, as I said, develop the relationship with the therapist in a different way. She was not expecting to die, but it got signed out as a suicide, so this would be a false positive. This is Mr. Nails. This is a very interesting flat plate of the abdomen. This is a patient that I had many years ago. He had schizophrenia as an underlying diagnosis. He was admitted to the psychiatric unit. He was decompensating. But during the time on the unit, he kept complaining that his belly was hurting him. The complaints persisted. I couldn't find anything on physical examination, so I sent him down to have a MRI done of the abdomen because I was concerned. I could tell by the way the patient was presenting that there was something wrong. Fortunately, there was an astute radiology technician. If he hadn't been astute, this patient would be dead. As he was rolling the patient into the MRI area, as you know, the MRI is a very strong magnet. As he got closer to the magnet, the patient began to moan and groan and pulled the patient back and asked, "Are you okay?" The patient said, "Well, I don't know, my stomach started hurting me worse." And told him to let him know if it hurt again. Started moving again towards the MRI machine, started moaning and groaning again. And the technician thought that something was wrong, talked to the radiologist. Radiologist said, better get a flat plate of the abdomen. There might be some metal in there. Long story short, radiologist called me, came down to take a look at this. I got, you got to be kidding me. Next phone call went to a friend of mine who's general surgeon. Within an hour, patient was in the operating room and they removed 46 2.5 to 3-inch nails that were in different states of decay. This patient was psychotic, was hearing these voices that were telling him that he had to do this. It had some meaning to him that he had to swallow these nails in order to keep something from happening. So he was listening to the hallucinations. Now, had this patient died somewhere along the course of doing this, and he easily could have died from a perforation of his stomach, had he died, somebody could have ruled this as a suicide. Now, we would look at this and say, there's no way this is a suicide, but somebody who was not in the mental health profession could see it as such, and it would not have been a suicide. It was an act of psychosis. And the last one is the case of an unlucky driver. I saw an example of this when I was in medical school. A forensic pathologist said how he would determine whether or not a car crash, a single vehicle car crash like this, was intentional or not. And he gave some examples, and he showed us one that he said he could conclude that it was suicide, even though there was no suicide note, there's no warning by the patient, family didn't think he was suicidal. One of the ways he found out was that he looked at the bottom of the shoe and he found the imprint of the gas pedal on the sole of the shoe, which indicated that this person's foot was on the gas pedal at the time that I think this person ran into a tree during broad daylight. There's nothing wrong with with the car or any other medical condition with the individual. And the forensic pathologist concluded that this was an intentional suicide by virtue of the fact that the foot was still in the gas with no effort to put on the brakes. This was ruled as an accidental death by motor vehicle accident, but this was clearly a case of suicide. So this would be a false negative. So let's now talk a little bit more specifically about this spectrum of self-harm that I was talking about, and what to do to identify where the person may be on that spectrum and what to do. A couple things to talk about before we get into that is the purpose of doing this is so that we can make our decisions by managing the emotions, observing and managing the emotions and the behaviors that contribute to these statistics rather than treating the statistics. So for example, if we see someone who statistically is in the high-risk group, let's say a widowed elderly gentleman living alone who has depression, that by itself doesn't mean that that person is suicidal. They may be hopeful and may have things to look forward to, but they're in that high-risk group. To view that person as a high-risk patient would actually be a mistake and may adversely affect the counseling, the progress of the counseling. Owning a gun is another example. What I call owning the gun or the misfire and the gun lock is just examples. We do know that the presence of a gun in combination with depression increases the overall statistical likelihood of suicide, but on an individual basis it does not. There are patients who are determined to end their life that could easily undo or cut the lock. There are many patients we know that are seriously depressed that own guns and would probably never ever use the gun to hurt themselves. And I've had patients, and you may have had patients as well, who said, "Doc, I was suicidal." I said, "Well, what happened?" So I put the gun to my head, pulled the trigger, and it was a misfire. And I've heard that so many times that I begin to wonder if that really was the case, because misfires like that don't happen that often, and certainly at that time the person pulled the trigger. Okay. So what do we do? I mean, what do we do? We don't read minds. What do we actually do to try to get a better handle on the level of risk and where the person is on the continuum, where we should be and how we should intervene? Well, what I found is most helpful is let's go ahead and identify those factors. Let's go ahead and monitor them and manage them. We'll go into some specifics how to at this point. So by the identification of those risks, we want to analyze the emotional risk factors, hopeful or hopeless, confident or desperate, and look at this as a continuum. To a person who is not feeling desperate at all, wants some treatment, they're not feeling hopeless, they expect that things will get better, to persons on the other end of the spectrum. We use those statistical risk factors, which I mentioned earlier, like past attempts, weapons, whether they have a plan or not, to help add to that analysis, not the other way around. I find that this is most helpful in terms of getting both an accurate read on the risk that the patient may be at, but also so as not to stigmatize the patient or drive them away from treatment. We've all had that experience where we compulsively ask a patient, "Are you feeling suicidal? Yes or no?" And many times patients, first of all, they don't like being asked that. It's too blunt. They sometimes get tired of asking it. They hear it every time they come into the session. They hear it maybe from other people on the treatment team over and over and over again, and it becomes almost this knee-jerk, "No, I'm not." And I think we can lure ourselves into feeling comfortable when we get a quick "no, I'm not," without really looking at how far along that continuum they may be. So one of the things we want to do then is once we identify those risk factors, those emotional antecedents, we then want to monitor those, and that's an ongoing process. Yes, during the particular session we want to monitor that, but the next session may be very different. It's an ongoing, very, very dynamic. And it's only for that moment in time. And let me add at this point too, in terms of medical documentation, just an important aside. Whenever you make a determination as to whether a patient is at imminent risk or not of making an attempt on their life, and that's an important documentation, if you conclude that they are not, make sure that in your note that you add, "At the time of this examination, I did not find the person to be showing any signs of imminent risk of self-harm." It's really important that you put that time factor in. It has a lot of ramification from medical legal. People not in the mental health business tend to expect that we can predict the future, and we cannot. And we cannot predict who will at some future date take their life or not. We are obligated to identify risk, monitor risk, but we cannot predict the future. But just make sure you make that notation of time in your note. And then we want to manage risk. We manage risk through treatment. We manage, importantly, very importantly, to educate the patient in terms of things that they can look for. So whether they're getting better or worse, things that we're worried about, and access. Access to care, critically important. We know that the window of risk when someone is acutely suicidal is very narrow. It can be hours, it can be a day or two. It's usually not long, but we don't want to miss that window. Patients need to have access. That doesn't mean they can call you 24/7, but they need to know what they can do at 4 a.m. when you're not at work and something comes up and they need to speak with somebody. It's very important that you have that plan in place for your patient. Okay. So what about diagnosing and treating underlying illness? Many times there are underlying illnesses associated with the patient feeling desperate and hopeless. It can be depression. It certainly can be unrelenting anxiety. It can be intolerable pain. The person feels hopeless. It's never going to get better. They got to get some relief. Nothing works. They think about taking their life. I put narcissistic injury in here, not because it's an illness, but it's so important, and I'm so struck. I was just reading another case this past weekend of children and adolescents in school being bullied to the point where they take their life. That's a really severe form of narcissistic injury. Certainly by knowing that someone's being bullied, i.e. the emotional impact, adverse emotional impact that's having on the person's self-esteem, would give us, a heads up into knowing that this person may be at risk and where they are in that continuum. And then unbearable grief and loss. There are patients that have had losses that are so severe they feel like they cannot go on, that they feel desperate for relief, that there's no hope. It can be loss of a spouse, a friend. It can be loss of a job. It can be a financial loss, but it can be different losses. So treating the underlying illness is only one aspect of managing the risk. So we know that not all severely depressed persons progress to suicide. Patients with mild to moderate anxiety can end their lives. We know that anxiety is an increased risk factor for suicide. The degree of pain does not necessarily predict suicide. There's a lot of issues right now with this whole pain scale thing. Is a fifth vital sign. Most clinicians, most physicians, providers right now are beginning to think that this probably is doing more harm than good, and we can't just rely on a number on the pain scale to get a measure of how distressed the person is. And in view of PTSD, most traumatized persons do not become suicidal. It's more than just the event. There are too many other factors that go into it. It doesn't have to be the extent of the trauma, but how that trauma affects that individual and how it's tempered by past experiences, etc. Okay. So again, it's essential to assess and address the emotional overlay to these disease states. And here's this may help to explain, when we don't do that, it may help to explain why we see people so perplexed when someone ends their life by suicide. We hear things like, well, why did he do this? It seems so normal. But the patient was doing so well, clinicians would say. Or we had no idea she felt so badly. But see, there we go. It gets back into the feelings. Had we been a little bit more attuned to the feelings that the person was having, rather than whether they said yes or no on a "are you suicidal" question, we may have had a little bit better insight into what was about to happen. So now, in terms of managing, I looked at really 5 major emotional antecedents or indications that a person may be far along in that continuum. There's whether or not there's an idea of ending one's life or a plan, the ambivalence about suicide, the warning signs that we may see or miss, inhibitions, whether they're in place or they've been compromised, and hope. So let's look at these specifically. In terms of ideation and plan, certainly it's important to determine whether or not there is the presence of specific suicidal ideation, a plan, or if there's been some suicide behaviors. I'll talk a little shortly about how you can ask those kinds of questions and more likely gets a honest, useful response. There are expressed versus implied ideation and plans. And by that I mean a person may come out and say, yes, I've had those thoughts, or yes, I have a plan to hurt myself. But they may not, but there may be some things that imply that in fact they have been. They can be things, as we've heard, things like getting a new life insurance policy, giving away prized possessions, calling up people that used to be important in this person's life and chatting with them and just saying, hey, I just kind of wanted to check up, don't know if I have any time to talk again, but just wanted to hear your voice. All of these indirect indications. And then there's the patient that's talking about it versus silent resignation. The patients that worry me the most are the patients that stop talking. When they are not talking, I cannot get a read on how they're feeling. I mean, nonverbal behaviors, yeah, a little bit, but not nearly as much as if they're talking. So I do everything I can to create an environment in which a patient feels comfortable talking, but you have to have a patient that's comfortable and willing to speak with you, or you're missing so much of the material that you need to make the determination of safety. And then you have your behaviorally expressed. You got your nonverbal warnings, and also I put down here the anxious patient. I wanted to emphasize that one of the relatively recent findings, important findings, is that a highly anxious, depressed patient is at a significant risk of feeling hopeless and desperate, i.e. at risk of harming themselves. We really need to address the anxiety, and we need just not, be condescending like, oh, things will get better, etc. We really need to help the patient find ways to reduce the anxiety, whether it's counseling, whether it's medications, whether it's helping them to get some activities going that help to give them some relief. Whatever it is, we really need to address that part of the patient's symptomatology. Ambivalence. This is a difficult slide, but I put it up here for a reason. And the reason being is that there's always some level of ambivalence in a patient that you see, even when they're at the far end of that continuum of they're getting to the point where they're feeling hopeless and desperate and they may make an attempt on their life. It's always there. You'll never meet anyone who's not ambivalent at all. Someone who's made that decision and they're determined to carry it out, they're not going to seek help. You're not going to meet that individual. Your goal is to amplify the positive or the survival side of that ambivalence and to basically buy time until treatment or whatever else needs to take place so that person moves away from that end of the continuum and they're at a much lower risk of actually acting out an act of self-harm. And when I do this presentation live, I put up this short video, but I did a screen grab of this just to make a point. This is an individual who was laying down on a railroad track. You may have seen this on the news. This is in New Jersey. It was about a year ago. Put himself on the railroad track, was waiting for a train to come by, and a security official happened to see this person, ran out, and tried to pull this individual off of the tracks, and he resisted. And this goes on for, gosh, it seems like 10 or 15 seconds, back and forth and back and forth, back and forth. And just as the guard is able to get him off the track, I mean, within a second or two, this train goes whizzing by at full speed. Now, most people would look at this and say, that person was absolutely, positively determined to kill himself. There's no ambivalence at all in this case. And I would contend, no, there was ambivalence. This individual could have waited until that train was about 20 feet away, going 50 or 60 miles an hour, and at that point, jump in front of the train. He did not. He got on the tracks minutes, if not longer, before the train was due to arrive. That, he may not say I was ambivalent, but that is an indication of ambivalence. And I point this out as an extreme example just to let you know that there's always some ambivalence there. Your job is to try to point that out or identify that and work with that. Work with what was it that kept you from pulling the trigger. We'll talk about the exquisite moment in a little bit, but that's the exquisite moment. What kept you from jumping off the building, or what kept you from swallowing those pills, whatever it was. Try to identify what kept the person going, and you want to work with that. And that is what I call the positive side of the ambivalence that will help to keep the person alive. Okay. And the warnings, we talked about the silent resignation. When patients stop talking or stop coming to the office, obviously that's a big red flag. Getting things in order, new insurance policy. I've seen that. I've had spouses call me and say, I'm worried about my husband. He took out a new life insurance policy, and I don't know why out of the blue he did that. Or somebody gets a new will, giving away previous or precious possessions. I've seen that as well. Or what we have heard about the acute serenity, where a patient who has been troubled and anxious and worried and hopeless all of a sudden is calm, everything's fine, doc, everything's going great. We know it's not going great, that there are things going on. I worry about that, as we all would. Okay. What about inhibitions? There are obviously the normal biological strivings to resist death, but things that can override those inhibitions and can increase the likelihood that somebody is going to act out on their thoughts. Substance. I put the 50% factor here. By that I mean that when they do autopsies on individuals who appear to have ended their life intentionally, in about at least half of the cases, there's some psychoactive substance on board at the time. In our culture, it's usually alcohol, but it can be other chemicals as well, things that tend to disinhibit the individual, cloud their judgment, allow them, so to speak, to carry out the act. Psychosis, we saw an example with Mr. Nails. He was not suicidal, but there are patients who hear voices commanding them to end their life, that's the only way out of their suffering. Dementia, confused individuals, accidentally, so those could be false positives, but also intentionally. A lot of persons with dementia, at least early on, they know that the course is not good, and they may choose to end their life because they feel as though it's hopeless, and they don't want to go down that road, even though there are treatments available, and there is hope, not in terms of curing the dementia, so to speak, but to help them with the associated depression and anxiety. And I put passion in here. Crimes of passion or passion that leads to suicide, the jilted lover, the person who's being bullied, that's really a narcissistic injury. It's emotional passions, feeling angry that they're being bullied. You have to, anybody who's gone through something that is extremely emotionally unsettling clearly increases the risk. So when you hear a patient that tells you, doc, I got to tell you something really bad happened or something that's really got me upset, that should increase your concern about where they are on that continuum. Hope, the belief that there's going to be a reduction in suffering and that you will do something to help them preserve the dignity as they're going through whatever it is that they're going through, whether it's bereavement, whether it's a patient with a terminal illness, whether someone who's done something, had something done to them that they're embarrassed at work in the communities, something that will help them preserve dignity will not only help them to be less likely to try make an attempt on their life, but will really help to solidify that therapeutic relationship with you. Again, when a patient knows that you're attuned to doing what you can to reduce their suffering as they experience it and to preserve the dignity in the process, will be a more compliant patient, a safer patient, and a patient who will benefit from treatment. On the other hand, a hopeless patient is a high-risk patient. So, well, how do you ask somebody if they're feeling hopeless or not? Again, I like to ask questions that are not just yes, no, are you not. I like to ask questions that get a little bit more information, but when it comes to hope, one of the ways I like to ask it is this way. When do you think things will get better? Even if I'm thinking that the person is feeling hopeless, I like to ask it this way because then I can get a response. They may say immediately, there's no way, doctor, it's going to get better. Okay, that's the person who's feeling really hopeless. But as there's pause, and they start to say, well, maybe if this happened, or maybe if we got a medication work, or maybe if the counseling starts to kick in, whatever, you get a better answer than whether or not you're feeling hopeful or hopeless. And then what about faith? Faith, we know, saves lives. We know that persons of formal faith, they have a lower incidence of suicide. We know Christians, for example, who practice their faith have a lower risk of suicide. Also, but faith in another way of looking at it, faith in the treatment process. We know for sure that patients that are engaged in treatment and have confidence in you as a therapist, they're going to do better. They're going to not only keep their appointments, but they're going to have a more favorable outcome. Okay, so what to do? Let's get into some specific to-dos and not to-dos in the remaining time that we have here. Your best tool that you have and your most reliable tool far and away is your clinical intuition. When I was a residency training director and we had to go through recruitment and try to match medical students with our residency program in psychiatry, the thing that I would look for is how intuitive that individual was. Because I knew that if I got someone into our training program who was intuitive, I could work with them to really fine-tune that intuition and help to turn them into a really good clinician. On the other hand, persons who did not seem to be that intuitive, usually, first of all, would not even be looking at a field of mental health. I think people who are both sensitive and intuitive tend to find themselves in this business. But that's what I would look for in recruiting. So what do you do? I mean, just instead of saying, yeah, I have it or not, you want to listen to it. You really, really want to pay attention to it. When your gut says there's something going on that I'm worried about, and there is, and you need to pay attention to it. On the other hand, patients may tell you certain things that statistically put them at high risk of suicide, but something's telling you that I really don't feel like this person is going to hurt themselves. Doesn't mean you dismiss it, but it means that you worry less and you set up your treatment plan accordingly. Well, what you want to do is you want to refine your clinical intuition. It comes about through experience. It comes about from analyzing when maybe you got things wrong. Those can be difficult times, but by learning about that, you can fine-tune that. But that is your best tool. You want to always pursue what does not make sense. When I'm training students in the mental health field when they're rotating through psychiatry, I tell them that if you want to really know what's going on with the patient, really, really want to know, just pursue whatever it is they say that doesn't make sense. Don't dismiss it and go on. Sort of analogous to when a surgeon has to do an abdominal search, try to find out what's going on, exploratory surgery. They go in and they kind of look at where's the inflammation, and they'll start going along the fascial planes where there's redness and irritation. Well, in mental health is similarly. When things don't make sense, behind that is probably a core conflict. And if you do that, if you keep pursuing that, you probably get to the reason that, or the issue that's troubling individuals. And that is pertinent here in terms of whether or not the person's suicidal. If they're having those thoughts, and in the process of trying to understand where they're coming from, something doesn't make sense, you should really spend time pursuing that. All right, some other tools. You want to fight denial. Obviously, you never want to conclude, oh, he wouldn't do that. He may do that. Even if the patient says, I would never do that. I would never do that because it would affect my family, affect my loved ones, affect my friends, blah, blah, blah. You can't accept it in face value. And this is number two here is a very difficult one, a very important one, and one that we tend to overlook because it is also very difficult to think about and very difficult to ask, and I'll also give you some suggestions on how to ask about it. And that is, whenever you suspect suicidal thinking or ideation, you must also suspect homicidal ideation or thinking. Again, don't draw the conclusion that he or she would never do that. How many times have we seen the person that's suicidal, got the gun to their head, turn the gun somewhere else, shoot someone else, or they've got someone that they're angry with, the gun's pointing there, and all of a sudden it turns and the gun's pointing towards themselves. There's a very fluid kind of back and forth between SI and HI, and most of the time homicidal ideation is not in the picture, but you don't know unless you ask. There's a tendency just not to ask because we think it just wouldn't be there. Often it is. In terms of shame, you have to use shame very carefully. You want to avoid things that are condescending. If you come across as paternalistic or condescending, that will be an affront to the dignity of the individual, and that will drive them from treatment. That will basically keep them from giving you the information that you need to do your work. So you have to be really careful in how you use it. Guilt, it has limited importance. The way that I use it at times, when a person is thinking of ending their life, I do ask them, I say, well, if you do, how do you think this will affect others? And the reason I do that is we know that one of the protective things against suicide is the support network, especially spouse or family ties. So I do want the patient to explore that, hopefully in bringing them down along that continuum to a safer level. What about suicide contracts? Do they work? The answer is we don't have any evidence at all that they work. What they do, they give a sense of security to the person asking for the contract, but I would venture to say that that's a false sense of security. And when you think about it, when someone's to the point where they're going to end their life, when that's going to disrupt relationships that have been in their family for years and years and years, friendships, whatever, they're willing to give up all of that. What is violating a little agreement with you? And in comparison, it's really nothing. So be very careful. There are some organizations you may work with that require that. If they require it, they require it, but it doesn't mean that you have to give it more value or any value, in my opinion. Okay. So a treatment approach, obviously personalize the risk that a person may be having and the way in which we reduce the risk through the treatment plan. Do everything you can to preserve dignity. In terms of treatment, whether it's counseling or medication, that's where you have to tailor make it. Not everyone who's depressed needs an antidepressant. Not everyone needs counseling. It's what is the best fit or best combination for that person. Sometimes we medicate, sometimes we counsel, sometimes we do both, sometimes we do neither. But tailor make it. And then educate your patient. To me, an educated patient is a safe patient. Vice versa, an uneducated patient is an unsafe patient. How do I do that? One of the ways I do that, at the end of every session that I have with every patient, as far back as I can remember, I always ask that person, do you have any questions? And I do it sincerely. I don't do it as a matter of fact, rush, I got to go on to the next patient. I stop. I say, do you have any questions? And I'll address them. You'd be surprised at things that you think a patient understands and they don't. So I always ask them that. And I've had patients say, Doc, I've never had a doctor ask me that before. Thank you for doing that. It is respectful, but it also helps to make sure you have an educated patient. Okay. We talked about the exquisite moment. You want to look at, if you have a patient that fortunately did not complete a suicide, you want to look at what led up to it and what they were thinking and what they were feeling when they decided not to end their life. That's something that you can build upon to reduce the risk going forward. Very, very important. The therapeutic window we talked about, you got to act quickly. And then last, when in doubt, consult. And what I mean by that is if you're really not sure, and hopefully you have some colleague that you can contact or somebody that you can call on the phone or write or even email to get their opinion. There are times, I've been in this business, mental health business, close to 4 decades now, and there are times I'll go to someone who's just gotten out of training and say, look, what is your opinion on this? Because I want to know. This may be something I just don't see, and get another set of eyes and ears to take a look. It's very important. Okay, so some specific how-tos. How do I ask somebody if they're feeling suicidal or feeling like they're going to act in a suicidal manner? And you can do it different ways, but this is some way that you can ask without hitting the person over the head with a question. Sometimes when people feel depressed and discouraged as you do, they wonder if life is worth living. Does this ever happen to you? That seems to be a way to ask that question that doesn't put people on the defensive and they feel comfortable answering that question. Similarly for homicide, which is a more difficult question, to ask somebody, are you thinking of killing anybody? A lot of people get really angry at you for asking such a question to even think that they would have that. So the way I go about it in a similar fashion, feeling depressed and suicidal sometimes makes people have unpleasant thoughts, like taking the life of others, even loved ones. Has that ever happened to you? Okay. The approach to the exquisite moment, similarly, it's hard to talk about the difficult time when you're about to take your life, but what we together, teamwork, right? But what we can learn from that is so important. Tell me what you were thinking when you had the gun to your head or whatever it was and decided at the last moment to live. It's a very fertile ground for information and treatment. Advice for getting rid of the guns. This is a sticking point, particularly in an area where we're, have a lot of avid hunters and gun owners. So the way I do it is this. I don't just tell them in a paternalistic way, you need to get rid of your guns. I don't do that. I do it more as, look, I'm working on your behalf. Safety is first and foremost. We want to put things in your favor for getting well and being safe. We know that when people are depressed and have ready access to guns, they have a much higher risk of injury or death. And I ask what they think about that. Okay. And some more do's and don'ts, and then we'll take a few questions. Assess the health of the support network. Encourage and reward sobriety, obviously, because of the 50% rule. Encourage compliance with their treatment, removal of weapons, obviously. Listen for future-oriented comments. One of the ways that you can tell whether someone is feeling hopeful or not is whether in their discussion there are things down the road. Like a person may be going through a rough period, but then they keep talking about, man, if I can just get to next summer, I got this time that I get to visit some people that I really wanted to see. That's a future-oriented aspect, and that's a good sign. And then therapeutic availability. As I said, it's not 24/7, but it involves some kind of plan that is 24/7 where that person can access help. And then finally, remember to reward yourself, recharge your batteries. You'll do better work for your patients. Don't blame yourself if there's a bad outcome. It cannot be determined. It really serves no purpose. And be grateful that to know that you are making an important difference because you are. Okay. And I just put this up. This is how I got my battery recharged. Recently I took a ride on the Hall Road all the way up to Prudhoe Bay with my dog, my truck, and my camera, and I saw things like this, and I came back really recharged. So thank you for your attention. I hope you found this to be useful.
We have time now. If anyone has any questions, please type them into the question box. We have none in the box at this point, so we're happy to address them for you. We'll take a moment. Susan, do you have any final words or anything while we're wrapping up?
I just want to thank Dr. Bautenheimer, and having heard this presentation before, I am again so impressed with its value, the depth of thought and experience, and just so appreciate you sharing it with us.
Appreciate that.
Okay. Well, we are going to get out a little bit early today since we have no questions, but a lot of times as you are sitting in your offices afterwards, actually we did just have one pop up if you'd like to take it, okay. How do you, how do you address generalized fear, or is fear an underlying factor to other items you mentioned?
Well, that's a complex question. I would, to get an understanding of the depth of the fear, if it's just fear in general, or whether it's fear about treatment or side effects, or fear of the outcome of whatever disease or process that's going on. But what I do is make sure that if I hear the word fear, or I see fear in a nonverbal behavior, that it gets addressed. It's one of those areas that's you know, we tend to try to placate, everything will be okay, pat on the back, etc. But that's not the business that we're in. We're in the business of feelings and understanding. So I would encourage the patient to talk about the fears. Where it comes up a lot in my practice is with most of my practice with PTSD patients, and their fear, more often than not, is they're going to have a recurrence of their symptoms, whether it's a flashback, a nightmare, etc. So understanding the fear, letting them know that I understand the fear, and then coming up with specific modalities to address the fear. So to answer the question in general, that's what I would do. I would need some specific cases or what the person was fearful of. Let me add though, if in any way it has to do with medications or side effects, I do provide my patients with a lot of reading material if they want that, in terms of understanding medications. It's part of having an educated patient is a safe patient thing, but I also caution them that when you read about potential side effects of medications, that they'll read about almost any kind of side effect that can occur, and I emphasize just the standard side effects of medications.
Okay. And one last one, can you speak to treatment for providers who have a client that commits suicide?
Yeah, and that's very, very difficult in terms of how to help the provider. I do find that the so-called psychological autopsies can be very useful. They're difficult. If you are working in a setting in which you have a treatment team, the team can have a meeting with those persons who are involved with the direct care of the patient and sit down and talk about their understanding of what happened, how people feel about that, what they've learned from that. For the clinician that's working by himself or herself, that's more difficult, but I would encourage that individual to be a participant in some professional organization that they can then develop those kind of collegial relationships. Most of us, fortunately, work with other colleagues, and I would encourage persons who have lost a patient to first of all ask themselves would they find it helpful to discuss that with other persons, not because of finger pointing that I missed something, I do something wrong, or in terms of learning from the event and understanding how the individual feels about that and what else might need to be done, such as counseling family or spouse, etc. What I would recommend not doing is to beat yourself up about it and to so-called suffer in silence and worry that you made a mistake. Again, the responsibility of whether or not someone takes their life is with that individual. We are not responsible for keeping someone alive. We are not responsible for preventing suicide. We are responsible for being available to that individual, and that individual may or may not have taken the opportunity to be available. It is a difficult part of this work, and that is one of the reasons why I gave thanks at the beginning. I'll give thanks again to those of you who are in the field.
Okay. Well, that's all the questions that we have that were typed in today. A lot of times when you're sitting in your office, you may come up with additional questions, or maybe there were ones that you felt you wanted to ask individually. You can send them to Dr. Bottenheimer at gbottenheimer@gmail.com or gary.bottenheimer@va.gov, or you can also send them to our Alaska AHEC office at UAA_AKHealthEDUCTR@alaska.edu. We will be happy to send them forward to Dr. Bottenheimer for you. Now, I wish to thank Dr. Bottenheimer and Susan Maley and all of you for joining us today. It was a very, very important topic that, especially in Alaska and also for our veterans, and that is very time sensitive to a lot of people and patients that are out there. Our certificates for social work contact hours or attendance certificates will be sent out in a follow-up email to all participants who request them. To help us provide the best trainings, please take a moment to complete the evaluation that will appear as soon as the webinar ends. We thank you today and hope you have a wonderful afternoon, and you may now disconnect. The webinar has ended. Thank you.